So I'll be very brief, not because Tobias has been very briefly with PharmAccess, because he has been with PharmAccess a long time already. He is also a professor at the University of Amsterdam, and soon he will move to Cape Town to represent SafeCare and PharmAccess at COHSASA. So that's a very interesting link, and I think, so that's it. For the sake of time, we'll do it like this, and the other things you can read in the booklet.
Thank you very much, Aaltje. Just half a minute to thank everybody to still be here and be awake. I'm very grateful to be able to present here as the last one of the family. In fact, I think I was the first child of the family, because when PharmAccess just existed and Joep started it together with Jacqueline and Geert in the board, I think I was the first employee, which was in April 2001. I thank you, Joep, for catching me when I was struggling with the public sector in Ethiopia after 10 years, and I thank you for employing me in this exciting organization. I also would like to thank Max and like to thank Onno for the enormous experiences that we have been going through in the last couple of years. They came in rather early, 2002, 2003, and I can tell you the types of horizons that Onno has created almost made me believe that the world is flat again and that he might fall off. But at the moment he was falling off, there was always Max who would organize the things and who would just get the operations right again. And that combination, I think, is just unbeatable. If I would ever win the 100 million in the Postcode Loterij or any other lottery, I would surely invest in the IFA, because that is a place to trust. And those two guys, I think, well, for me it was really the best combination. Anyway, so far the past. I would also like to look a bit at the future. I think I congratulate Michiel, because he is only here for a year, and he presented our organization as if he has been there for the last 10 years. And I really think that is an achievement. And finally, for my next step, Stuart, where are you, Stuart? There he is. Stuart, the managing director of COHSASA. That will be the next step for me, and I'm very grateful you're here, and we are going to link up COHSASA and PharmAccess in a tremendous way. Let me present on the SafeCare Initiative in a very short way, because I've promised a case to do so. We've seen this, thanks God. Everything was explained already by Michiel. I would like to make a small variation at the end of this slide. We all know about demand, and we know about supply, and we know about trust. Onno will talk about trust in the next presentation as well. What I would like to do is basically put SafeCare in the middle there. I take the liberty, not at the bottom, but in the middle. I take the liberty to really emphasize that quality is key. If there's no quality, if there's no drugs, if there's no doctor, the willingness to pay of people going to a clinic will go down, and the sustainability of any prepayment mechanism, including insurance, is at stake. What is quality? Well, there's all kinds of definitions for quality. We've put a couple of definitions here on the list. There's, of course, quality as experienced by patients and as delivered by doctors to their patients in the social way. There's the medical technical quality that we all care about. There's functional quality in terms of what is helpful for the care received by the patient, in, for example, the hygiene. And there's organizational quality, organizing your work, your workflow, your processes, and so on and so forth. And what is the nice thing about quality, it can be measured, and it can be measured in different ways. It can be measured in terms of assets, in terms of skills, in terms of processes, and eventually, of course, in terms of outputs and outcomes, which is the most challenging and most difficult part of the work. And the nice thing about things that can be measured is that they can be improved, because if you have a baseline, you can improve things. You can purchase assets, you can train staff, you can implement standard operating procedures, you can provide technical assistance, you can implement external quality control systems. It can be done. And these led to the ideas and concepts that basically ended up in SafeCare. We wanted to have a quality improvement system in place that was doable in Africa. In other words, be a rewarding system, a system that rewards each and every small step of improvement with a recognition, and motivates people, and it doesn't disorient people from the real goal. It should be practical and solution-oriented. It should be rewarding, with specific and recognizable products that can be IP protected. It should be data-based and widely available. It should be financially sustainable. It should be possible to link this system to performance-based financing, like the medical credit fund that we have just heard about. It should provide benchmarking across networks and across countries, and it should be possible to work within the legal framework of national governments, and where possible, of course, liaise with existing or new national institutes that protect quality. And that's how the SafeCare Initiative came up. 3 organizations, we've mentioned them already, COHSASA, PharmAccess, and Joint Commission International from the United States. The launch was in Cape Town in March this year. It was an excellent one. And we worked along the same principles. Basically, these principles entail you need to have standards which are innovative and realistic in the African setting. And you need to develop a stepwise improvement process along those standards that reward people for each and every step in quality that they make. And those will lead then to increased efficiencies of the healthcare facilities. It will qualify them to negotiate, to participate in a health insurance fund program. It will attract loans from the medical credit funds. It will increase patient flows and sustainability, and it will improve reputation and transparency. And all in all, it can increase trust by clients, insurers, investors, banks, and governments. And I'll come back to that in a second. Basically, SafeCare, and I'll try to speed it up as much as I can, Kees, is concentrating on the, let's say, a little bit lower categories of providers. So we call it categories 3 up to 6, going from, let's say, health shops and nurse-driven clinics up to the district hospitals. And we use international standards, but we accept local solutions, like this one. This is perfectly acceptable, even though it's maybe not the multi-million chair that is used in the AMC in Amsterdam. We use a phased approach, and basically there's 3 phases. Phase number 1 is just to identify clinics, and we use the SafeCare Essentials tools for that to really find out which clinics are eligible and which ones are not. In the second phase, there is a graded and circular annual improvement process going on, and that is really supported by the SafeCare tools, and 6 monthly or 12 monthly visits to check whether things indeed improve. And it is supported by a continuous technical assistance program. And phase number 3, for those clinics that went through this whole phase and are eligible for accreditation, there is the accreditation phase. And that's where COHSASA plays the 100% role. So if we go to phase 1, clinics score a certain score that is on a very simple tool. It takes 1 or 2 hours, and we have a first idea whether they're eligible or not. In phase 2, we go through the graded recognition. We assess the clinic in a much more in-depth way. There's all kinds of tools developed for those clinics, and we get certain scores of the clinics. At the moment, more than 100 clinics have already joined in the SafeCare program, and all kinds of certificates of improvement are currently being distributed. We use all kinds of software applications. The databases are established in such a way that if we assess a clinic, then within 2 or 3 hours, a first interim report can already be sent over to the clinic. So the clinic has a bit of an idea of what's going on. It's all automated, and it's all related to the graded stepwise improvement process that is rewarded by improvement certificates. There's 5 certificates, SafeCare 1 up to SafeCare 5, which is the whole phase of improvement. And if you have reached the level of SafeCare 5, you can go for accreditation. And accreditation is the real serious business with COHSASA. Basically, this is the way a certificate of improvement looks like. The first certificates have been given to different clinics, and we think that it should look like this in the future. This is a bit wishful thinking still, but we're looking here at a picture of Lagos. Here are all the clinics that are involved in the Health Insurance Fund program, and here are the different SafeCare certificates and levels that they have worked upwards to in the last couple of years. The third phase, of course, is final accreditation by COHSASA. COHSASA based in South Africa, but working in many countries in Africa. So basically, to finalize this talk, the impact of quality is appropriateness, the right care at the right moment for the right patient. It's transparency, benchmarking, and accountability. It's access, willingness to pay, and it's creating trust, and it's cost effectiveness. And basically, we think that the SafeCare is one of those institutions, and we've heard a lot of stories about institutions earlier today, that can contribute to the trust in a healthcare market. It's only one of them, but it's a good one. It allows for independent external evaluation. It can rate and benchmark clinics. It will increase transparency and therefore reduce risks and reduce transaction costs. For patients, this means they know where they're going. There's some kind of a certificate, and this place is a good place to be. For healthcare providers, it means they might get better access to loans because they are certified to a certain level. For banks, it can mean, okay, we can provide loans to this clinic because the clinic is doing a decent job and is not spending the money on a Mercedes-Benz instead of on taking care of the patients. For donors, it means we can invest our money safely in those clinics because they are every time again being accredited and every time again being certified. For governments, it means we have maybe a basis here for a legal framework that can monitor and regulate the quality in networks of clinics. And for insurers, eventually, it means, okay, we can possibly reward the better performing clinics with a better payout as compared to the lower performing clinics. And I think this is it, and a new record.